I want to thank you for coming here today. We're going to spend the next few minutes talking to you about spinal decompression therapy, the benefits of spinal decompression therapy, and what we do to get you well, not just better, treating the cause, not just the symptoms. We're also going to go over some general anatomy and some things on the screen that are going to show you exactly what we do. I'm going to show you some things that we do specific to spinal decompression therapy in our course of care. Most of you that are watching this have probably been through the epidural steroid injections, the pain medication, the narcotic pain medication, the muscle relaxants, general chiropractic care, the acupuncture, and maybe even a surgery or two, and are still having problems. What we do is we get down to that cause. And by getting down to that cause, we're able to get you well and keep you well. So here we're looking at a good vertebra. Here's the front of you right here. Here's the back of you. And if you notice, if you ever given a massage, you can feel those bones sticking out. Here we're looking straight down. There's the outer part of the disc with cartilage, and there's the liquid center portion. And that liquid center portion is what gives us our disc height. It acts as a shock absorber. Now it also gives us our area for the nerve to exit, as well as motion in the spine. These are called the facet joints. And when we have a nice big disc space, we have good motion. Why most of you, when you're having problems or you're having pain, you feel very stiff, you don't feel like you had the motion, you can't bend, you can't move your head as good as you were. Now we're looking at a disc that's become dry or degenerative, and you can see how this disc has lost its disc height. When that happens, the disc will bulge, either to the left, to the right, or what's called a bilateral bulge. This one you can see is a left greater than right. When that happens, it then stenoses or occludes, and it takes up that area where that nerve exits, creating the problem from that point anywhere on down. Now, as we start to compress and that disc loses its height and it starts to degenerate and lose the fluids inside, the disc material now oozes and sits on that emitting nerve, creating a stenosing or occluding of this area. And just like as if you were to press on a water balloon, that water balloon has to bulge one way or the other. If I press on the water balloon over here, it bulges to the left. If I press on the water balloon over here, it bulges to the right. It also creates stiffness because these facet joints don't have as much motion to move because of the loss of the hydration inside the disc. What we're able to do in spinal decompression therapy is, since these discs are grown into the tops and bottoms of each of these vertebrae, instead of this downward pressure, which causes that loss of hydration and causes that bulge, we're able to create a distractive force. And when we create a distractive force, it creates a negative pressure, which allows for these waters, nutrients, and oxygens to vacuum back in. It allows for these protrusions or herniations to vacuum back in, now giving us a nice big area for the nerve to exit. In spinal decompression therapy, what we do is we isolate one individual disc and only one individual disc by isolating on the computer an angle that corresponds to that one disc. We tell the computer the diagnosis, and it creates that angle, and then it creates a negative pressure inside this disc. Not that downward positive pressure, which causes that loss of hydration, causes the bulge, but a negative pressure, now allowing these waters, nutrients, and oxygens, which are right outside that disc, to flood back inside the disc, to vacuum back in these protrusions or herniations, now giving us a nice big area for the nerve to exit, now treating the cause, not just the symptoms, now getting you well, not just better. Again, no medication, no injections, no surgery. One of the examples I like to use is, let's say that you're driving your car and your left front tire of your car goes low, and you look at it and you go, what should I do? Well, I could repaint the car, I can put a new interior in the car, I can put a new stereo system in the car. Car looks really nice, but you still have a left front tire that's low. Where's the air? Right outside the tire. Until you get that air from outside the tire back inside the tire, it doesn't matter what you did to that car, it's never going to run right. And then you have secondary problems with the car, the tie rod, the bushings, the bearings, the alignment, the tire itself, because you didn't address the cause. It's the same thing. You can take all the pain medication, you can do the epidural steroid injections, you can do the general chiropractic or the physical therapy or the acupuncture, but you're not getting to the cause, and that's the fluid from outside the disc, just like getting the air back inside the tire. Now this is looking at the low back, one of our number one spots that we treat. We do neck and low back. And this is looking on a side view. So this would be your belly right here. This would be your bottom. We see that there's a great deal of motion in the spine. But if you were actually to look at just one little segment, not a great deal of motion in one segment, but orchestrated with all the other segments, they do very, very well. So it's very important, because I want to talk about some of the surgeries that they do in order to try to get these problems and the failure rate. Let's talk about the failure rate for a second. The failure rate of surgery in a good candidate is only 50-50 up to 1 year, meaning that 50% of a good candidate are going to fail and 50% are going to succeed up to 1 year. So some of you that are watching this that are 40, 50, 60, 70, 80 years of age, that doesn't even give you that chance at that 50-50. Now that 50% that succeeded up to 1 year drops down to 15% successful at 8 to 10 years. One of the things they do is what's called a laminectomy microdiscectomy. A laminectomy means that they go into this area right here and remove this bone in order to give a window for the surgeon to get to that disc. And then they do the microdiscectomy where they snip off this piece of disc to give you a larger area for that nerve to exit. The problem with that is there's still a portal of exit for that fluid to come back out. Usually 2 to 3 years after a patient has that surgery, they're right back where they are. And then the doctor will do a second one either on the level above or below, or talk about lumbar fusion. When this disc dries or degenerates and it puts pressure on that sciatic nerve, the doctor will go in and is to make an incision and then plates, bolts, and screws and get the sacrum hooked up to this L5 so there's no motion in there. Well, then what happens is that creates what's called interthecal pressure, increased interthecal pressure to the disc above. Once we fuse an area, the above area goes bad. 3 or 4 or 5 years, maybe 10 years later, go back in, fuse a second one, fuse a third one, fuse a fourth one. That's why you need to do everything possible non-invasively in order to get well, treating the cause, not just the symptoms, without medication, injections, or surgery. It starts with pain, then it goes to numbness and tingling, and then it goes to motor loss. And you know what? It always progresses because gravity's never going to stop acting on us. Spinal decompression therapy and what we do to get you well, not just better, treating the cause, not just the symptoms. Now, when you notice that you have a good disc, you have plenty of room at what's called the facets, where the motion of the spine is. However, when we lose that disc space, that's when we start to get these facets too close and we start to lose our motion and we get real stiff. We're looking straight down at the disc, as if I was to cut you in half and I'm looking straight down. This is the front of you right here. Here's the bone that you feel to the back of your spine. Here's the outer part of the disc, which is cartilage. And here's the center liquid gel portion. And we can see how that liquid gel portion is sitting on that nerve and stenosing or occluding that nerve, not giving us enough room for that nerve to exit. If we look over here, this is a nice big area for that nerve to exit. So if you have problems or pain on both sides, this would be on both sides, whereas this one is showing a left greater than right. Now, if we try to look into this hole like this, it's as if now I turn you sideways and we see that same bulge occluding or stenosing that area, not giving us enough room for that nerve, with this loss of disc height as opposed to the disc right above, which is nice and big with a nice big hole for the nerve to exit. Now, we must remember that these discs are grown into the tops and bottoms of each of these vertebrae. We must remember that it's this downward pressure on that disc that causes that loss of hydration and causes that bulge. And we've got to remember that we're about 70% waters, nutrients, and oxygens. Everything that used to be inside that disc is right outside the disc. It only takes the weight of a dime for you to have the problem from that point anywhere on down. So what we do is we tell the computer to distract this individual vertebra this way, and to distract this individual vertebra this way. And in doing so, this creates a negative pressure inside that disc, which allows for these waters, nutrients, and oxygens to vacuum back inside the disc. It allows for these protrusions or herniations to vacuum back inside the disc, now giving us a nice big area for the nerve to exit. I want you to watch right here as I distract these two individual vertebrae. The disc material starts to vacuum back in, starts to take the pressure off the nerve, gives us more fluid inside the disc, now giving us a nice big area for the nerve to exit. If I want that L5S1, our table is going to create an exact angle to get to that L5S1. If I need an L405, we set the computer, it changes the angle to isolate that one. If I need an L304, it changes the angle to get to that one disc so that we can isolate that one disc and only one disc to create that negative pressure. That in itself is what we're doing to treat the cause. You've got to try non-invasive procedures. You can't mask the symptoms. You can't go after something that's going to just give you a temporary relief. We work to get you well, not just better. We work to treat the cause, not just the symptoms. And when you meet with your doctor after I finish, they're going to also tell you what we do to give you all the assurity possible that we not only get you well, but we give you the opportunity to stay well. I want to thank you for the time that you spent with me. You're next going to go see your doctor, who's going to go over your individual x-rays and your individual condition with you and prescribe a course of care to get you well, not just better.